Good morning, good afternoon, good evening, everyone, wherever you are for joining us from a very warm welcome to this PMNCH dialogue. This is the fifth in the series of dialogues that we organize, captioned as Ready, Set, Implement, focusing on efforts to accelerate implementation for reduction of maternal newborn child mortality. Today's discussion, colleagues, could not be more timely or necessary. Malnutrition remains a global crisis touching every country, every community, and every corner of our health and development systems. According to estimates, in 2022, nearly 390 million adults were underweight and about 2.5 billion were overweight, including almost 900 million living with obesity. That's not a health problem, that's a planetary crisis. And it's failing our women and our children most of all. Around 148 million children under the age of 5 suffer from stunting. 1 billion adolescent girls and women are undernourished. 1 billion women and girls. Let these numbers sink in, because malnutrition in women and adolescent girls is not just a nutrition issue. It determines their health, their autonomy, their education, their livelihoods, and their ability to birth safely. In fact, malnourished mothers are twice as likely to die in childbirth. Their babies are more likely to be born with low birth weight, vulnerable to infections, disease, and tragically, in many cases, death as well. This contributes to deaths of over 800,000 newborns every year. So yes, malnutrition is killing women and babies. It is also costing the global economy over $1.6 trillion annually in lost productivity and potential. And here's the thing, nearly $28 billion were pledged in the recent Nutrition for Growth Summit in Paris. But the real question is the one we are here to confront. How do we make those dollars count? How do we turn those commitments into meaningful results for women, for adolescents, and for newborn? The World Health Assembly last year passed a resolution that extended the decade of action of nutrition and the momentum for the Nutrition for Growth Paris Summit. They all give us a clear mandate, but they also give us a moment for reckoning. Because at this stage in our global journey, there really is no excuse. We have the evidence, we have the financing commitment, and we have the policy levers. We now must ensure alignment and action. Through this dialogue today, we will hear from champions who are pushing the boundaries, integrating nutrition and maternal health, financing frontline action, and scaling community-led solutions that center women and girls. Let's listen deeply, challenge assumptions, and most importantly, leave this space with a clearer sense of what will it take to implement action. Before we begin, a couple of very quick housekeeping rules. Please do use the Q&A panel throughout this dialogue to pose your question. I will try and take them as we go along to the panelists for their responses and integrate it into a conversation. And my request to the dear panelists, at any point they want to react to something they heard from or want to build upon from one of their co-panelists, just use the hand feature and I'll try and come back to you as soon as we can. So let's get into it. And if I could please first come to you, Afshan. The Sun movement has played a critical role in bridging grassroots action with global commitments. From where you sit as the Assistant Secretary General, how do we keep youth, civil society, and governments mobilized around this agenda? And what lessons from the Sun countries can help us institutionalize this work for real-world impact? Over to you, Afshan.
Thank you so much, Rajat, and it's a delight to be here with you and so many of my colleagues on this panel. So Sun is working on 3 fronts to keep government, civil society, and youth mobilized and accountable around their commitments. The first is supporting the right policies, and you alluded to that already, such as embedding maternal and child nutrition into national nutrition and development plans, health policies, and even climate and food system strategies. So in countries like El Salvador and Sierra Leone, this has been done by shaping legislation on breastfeeding and supporting large-scale training of breastfeeding counselors, establishing the regulatory frameworks for food marketing, and incentivizing smallholder farmers to grow more nutritious foods. Second is the accelerating implementation. Some countries are localizing nutrition for growth ambitions by better articulating maternal and child nutrition interventions within primary healthcare, including interventions like exclusive breastfeeding, micronutrient supplementation, and management of wasting. And this has been based on better costing and budgeting of interventions in the health sector and focused collaboration and partnerships amongst government, civil society actors, UN agency, and the international development banks, lending to much more cost-effective solutions that not only save lives, but reduce long-term risks like stunting, anemia, and childhood obesity. So both Ghana and Ethiopia are examples of some countries that have made significant nutrition commitments pertaining to maternal and childhood health. And the third element I would say that is very important is consistent advocacy. You already mentioned countries that supported the WHA resolutions to extend the WHA global targets for maternal, infant, and young child nutrition beyond 2025. And along with civil society, working towards prohibiting the digital marketing of breast milk substitutes. So we really saw that SUN as a movement, based on a strong country voice in these discussions, lent political clout to the importance of targeted nutrition interventions through efficient investments in the health sector. And at a time of declining ODA, high-impact nutrition interventions delivered through the health sector and WHO's role in making sure that nutrition is firmly embedded as part of the universal healthcare agenda is really key. So for SUN, we see that the national level multi-stakeholder platforms are the backbone of the movement and give space to civil society, women's group, and youth in shaping the national nutrition agendas. And as a movement, parliamentarians, academia, media, local leaders, and communities are all important stakeholders in ensuring accountability for the Nutrition for Growth agenda. And I was very pleased to be able to work with World Vision and 4SD to make sure that the youth voice and action, along with some civil society, are really a critical component of future-proofing nutrition. So post N4G, SUN remains a driver of joined-up action, ensuring that maternal and child nutrition, especially in the first 1,000 days, stays at the heart of health and development investments. And we're really pleased to partner with many of the stakeholders that are on this panel today. Back to you, Rajat.
Thank you. Thank you so much for that, Afshan, and for situating the leadership of country, community voices, and as you said, national platforms, which are backbone of the movement that we have, but also, as you ended with the call for joint up action. Really appreciate your thoughts, which help us situate the rest of the conversation very well. And if I could come to you, David, you have been a champion for decades for some of these issues. And a strong voice, particularly on systems leadership and intersectoral action. David, if I could ask you, what do you think are the most strategic levers that we can pull now to elevate nutrition in context of maternal and newborn health frameworks, particularly in the context that Afshan also mentioned, where we are facing serious global challenges, aid cuts, and other forms of challenges to the multilateral system. Over to you.
Rajat, I'm most grateful to you and colleagues for inviting me. As you say, I've been working in this area really for most of my professional life, about 5 decades. And I think I'm a bit embarrassed, actually, that we're still struggling with a very high burden of malnutrition internationally. And it's quite hard to get political leaders to understand how serious it is and how they need to do more. So I thought I'd start by first couple of minutes just being quite stark, really. You know, all forms of malnutrition are bad for people. And if we look at the death statistics, you know, we're now at a point where nearly half of the deaths that occur in our world today are linked to what people eat or don't eat. Now, that's pretty serious. More deaths from food than from smoking, for example. And look at the amount of trouble that's gone into tobacco control. And it's increasing. Now, I've watched over the years as people have tried to implement what are called nutrition programs. And by and large, they don't work very well. I mean, you do manage to get some kids to eat more, you do manage to save lives, but in the long term, nutrition programs don't dent what you just referred to as a global crisis in your introductory remarks. And that's why what Afshan just described in the Sun movement is so important. It's really necessary to ensure that nutrition is in everything. I don't think enough young doctors know sufficiently about how to respond to malnutrition or obesity in children. I teach in a medical school and I see this. I don't think there's enough attention to nutrition right across governments in far too many countries. But I have seen change, Rajat, and here are some examples. First of all, the fact that now there are many people in the world talking about food systems means that we have many more opportunities to include nutrition and nourishment in discussions on agriculture and food policy. The fact that there's much greater attention to social protection and ways of protecting people on low incomes from experiencing hardship means that we've got a chance to bring nutrition more deeply into social protection. And then actually during Nutrition for Growth, there was a big interest from the education sector in being more involved in bringing malnutrition into education right through life, not just with school meals, but making nutrition a part of the curriculum. And so there is hope. But goodness me, we need to move quick because more and more people are getting obese and are suffering long-term health consequences of eating the wrong stuff. And more kids are experiencing malnutrition because of conflict or because of climate change and other factors. So let's keep going and follow the message that came through really strongly in Nutrition for Growth, which is integrate nutrition into everything. Thank you.
Brilliant. Thank you so much for that, David, and really helping us situate very clearly and concretely, not just system thinking, but also the great sense of urgency that you ended with, that we need to work with if you're going to capitalize the gains that were made. And a perfect segue, actually, to Agnes Sukat, who's joining us from AFD as well. And Agnes, you did not only host the Nutrition for Growth Summit, but you are a great champion of these issues yourself. And as we heard from both Afsan and from David, how catalytic that summit has been in terms of situating these issues at the forefront, the commitments that we have had. So, Agnes, from your perspective, what should be the priority moving forward, and how is AFD looking at the next steps? Over to you.
Thank you very much. Thank you, Rajat. And yes, indeed, France hosted the last Nutrition for Growth Summit back in March. As you know, the summit is organized every 4 years at the fringe of the Olympic Games. And one thing that we need to announce, at the forefront is that the summit showed a momentum that was kept on the nutrition agenda with a commitment of more than 27 billion to the nutrition agenda by the different partners. But one thing that is less known is that most of these commitments come actually from public development banks. And there is really an awakening of the public development banks, including the multilateral development banks. And the World Bank has been a champion for nutrition for many years now and has demonstrated how one can design effective, high-impact projects in nutrition. But now there is really the realization that this agenda is critical, not only because it is a health agenda, and this has been reiterated how important nutrition of children is, as it underpins more than half of the mortality of children less than 5, but also the importance in terms of the impact that we are expecting from climate change and from environmental changes in the area of biodiversity. For example, we know that not only climate change affects the productivity and the quantity of food produced, but that both climate change and biodiversity loss affect the quality of food and the quality of nutrients in that food, and that the food is less nutritious when it is produced under the new circumstances the planet is facing as compared to yesterday. So there is really an agenda today that the global community is committed to. Certainly France and European countries are, but we need to look at this in a different way. And one first thing is, I think we need to first acknowledge the progress that was made, and particularly the progress that was made by this community, by the PMNCH plus community in advocating for this agenda, because we see child mortality going down, we see maternal mortality going down in many countries, and it is partially linked to high impact interventions that are delivered as part of maternal and child health packages, including micronutrient supplements, including growth monitoring and information of mothers, including interventions around exclusive and prolonged breastfeeding, as well as weaning. But there are areas in which we're not only making slower progress, but we may actually be going backwards. The first one was mentioned by David, is social protection. We know that rich kids are not undernourished, right? The question of undernutrition, poor levels of nutrition of young children and of women of reproductive age is really linked to vulnerabilities, including economic vulnerabilities. When we look at the pattern of malnutrition in a country like Pakistan or Nigeria, it is very clear. So there is an unfinished agenda that is linked to poverty and to the stress that societies experience. And there is really a need to rethink nutrition together with social protection. We have incredibly strong evidence of how safety nets linked with nutrition programs are effective, and we need to be much more systematic in the way we implement those to address the questions of vulnerability together with the question of nutrition, whether it is in in regular setting or emergency settings. And yes, we are now living in a very difficult phase in which we are all struggling with the decline in funding for humanitarian programs, but also from some maternal and child health programs due to the withdrawal of US government from funding these programs. And we really need to make sure that we don't throw the baby with the bathwater, and we make sure that in the programs that keep being funded, including through the funding from the European countries, which are the main funders of these programs, that we keep giving very high attention to these safety net programs that address nutrition, to looking at the impact of food insecurity on vulnerable populations, because this is not only a problem that is already here today, but may actually increase because of increase in conflicts and increase in environmental stress. So we need to have in every single country a sort of sustainable way to build cash transfer, social safety net programs that are accompanied by strong nutrition program. And it's not the case everywhere yet. And we need to do that, and we need to get governments to be involved in this funding. Government of Nigeria is working on this now, and to really have this very strong social protection cum nutrition program. And my last point will be about the new challenges linked to obesity and the rise of metabolic disease, including in young children now and adolescents, which are facing this new crisis. And here I would say, sadly, lamentably, we've been going backwards in many ways. That epidemic of obesity is spreading around the world. It's spreading in low-income countries. We have countries like South Africa, where already 30% of the population is overweight, while still having some undernutrition problems. The Middle East and North Africa are affected by what can be called an epidemic of diabetes. And yet our food system is actually contributing to that, and our food system is increasingly globalized, is increasingly relying on less and less diversity of food, on production of food that is not nutritious or is even harmful when it is high in sugar or salt, particularly high in sugar. And there is really a major challenge for our community, because as much as we have had success in the health community, and I think we should really embrace that success and document it and continue the hard work, as much as we have large programs that have shown success in social protection, and we need to expand and do more. But when it comes to linking agriculture programs and support to small and middle-sized enterprises to produce nutritious foods, in supporting agroecology and women's headed agriculture, in fact, we not only are not progressing, we were often lagging behind, and we still have a lot of work to do and a long way to go to implement those policies that will address this, whether these are policies of SSB taxation or sugar taxation, at least not subsidizing sugar, but also policies that promote diversified and nutritious food. And that's going to be absolutely essential as we have entered times in which we can no longer trust that we will have a stable ecosystem. Thank you.
Thank you. Thank you. Thank you so much for that, Agnes, and clearly outlining, as did Afsan and David as well, progress made, challenges remain, but also something very important that you repeatedly said is the need for us to ensure intersectionality and ending silos, and how do we address this multitude of challenges that continue to undermine progress and deepen inequalities, as it were. We do have a little bit of time, so I do want to come back to this panel before moving into the second panel, which will be looking at policy and financing issues. So I want to come back to Afsan, David, and Agnes for a quick response in 1 minute or more, if you can just accommodate us. And there is also a question I wanted to pose to you, which has come in the chat. What are some of the effective accountability mechanisms that you think could work, holding governments to account to these commitments? And then the other question that came, which I thought would be useful for your response and reflection, is that even though we do have better data today, we still do not have visibility of the magnitude of death and morbidity that is happening because of malnutrition. So any brief reflections on what can partners working on these issues do to ensure accountability and drive progress? Afsan, if we could start with you, and then we'll end with Agnes before moving to the next panel. Over to you, Afsan.
Thank you very much, Rajesh. I think to get some lasting action, particularly on dealing with what is clearly a crisis, as you clearly said, of malnutrition, I do think we need to tap into more community-based solutions to scale what works, and making communities, including young people, full partners in health and nutrition programming. So I think that lived experience is extremely important when we're developing policies and strategies. Secondly, I would say that, institutionalizing action means building inclusive and multi-sectoral governance. So this multi-sectoral platform that brings together stakeholders from social protection, from education, from health, from water and sanitation, is an extremely important part of strengthening the intergovernmental collaboration and breaking the silos. But this element of bringing together government, civil society, youth, and business and development partners to co-create solutions is also an important mechanism for ensuring better accountability. I think we've seen countries, I'll give a few examples. Zambia, 10 line ministries work together with civil society, the private sector, UN agencies, and donors to launch the first 1,000 Most Critical Days program, an initiative that led to 8% stunting reduction since its launch. In Nigeria, which Agnes mentioned, the Sun Civil Society Association supported the Federal Ministry of Women's Affairs and Social Development to develop a national guideline on women and girls empowerment. And in Vietnam, civil society organizations are collaborating with the Ministries of Health and Media to implement the use of an AI tool to monitor and flag breaches of code to the breast milk substitutes. So I raise these as practical examples where a coalition of partners helps to strengthen that accountability and strengthen implementation of actions. And that means both a governance and a monitoring mechanism. And as you rightly pointed out, the data and evidence to show both what changes are being made, but where are the biggest obstacles and bottlenecks, and how can we address those in a joined up manner in a meaningful way. And I would be remiss, and I hope Dan will speak to it later, but I also think the whole point of the power of frontline workers and community workers, and what we're learning from them is being vital to bringing interventions closer to families and communities, particularly in underserved areas. Because as much as we've seen progress in some places, I still think we have numbers that indicate far too many people are being left behind. And with the current aid cuts, both efficiency, effectiveness gains, and mechanisms for governance that strengthen data systems, monitoring, and accountability are essential if we're going to see the needed transformations. Thank you, Rajesh. Back to you.
Thank you. Thank you very much for that, Afshan. And indeed, some very clear, concrete examples of how we can move forward. David, to you for brief reflections, and then back to you, Agnes.
Thank you very much indeed. First of all, as has been said by others, we haven't been idly doing nothing over the last 15 years, but there's a lot more that must be done because things move faster than us. What we found working with World Vision and the Sun Civil Society Network and youth leaders and so on during the year 2024, leading up to Nutrition for Growth Summit in March this year, was that there's an awful lot of knowledge in local communities about good nutrition and what's needed to make it happen. We stimulated dialogue. 12,000 people, mostly young people in 54 countries, discussing what they think should be done about nutritional challenges. In nearly 400 dialogues that were synthesized, 3 big messages came out. Number 1, focus on those who are most vulnerable. Number 2, have interconnected responses that bring different sectors and stakeholders together, close to people's households. Number 3, involve everyone in making them happen because it's everyone's business, frontline workers and more. So just to say, discuss and debate, yes. Connect and act, yes. And account to the people, yes. And use dialogues as a way to make it happen. I think it makes a huge difference, and we've seen it all over the world in the last few months.
Absolutely. And having attended some of them, David, I can vouch to the veracity and success of them. And thank you really for shepherding them. Agnes, final thoughts before we move to the next panel members?
Maybe 2 points. The first one is really realizing that one of the first consequences of the cuts in development assistance from the US government is the cut in generation of data. Actually, the US governments with different programs, whether it was USAID or US CDC or PEPFAR, always had very, very strong data components and data investments because it has such a high level of accountability to Congress. So there is, of course, the tool that we all love, the demographic and health survey. There are facility surveys, there are health expenditure tracking surveys, and there is the whole surveillance of communicable and non-communicable disease. And that is a major area of concern. We know that, in fact, the global community relies more and more on modeling. That's the case of WHO. In fact, most of the data now are modeled, and we have actually less and less reporting of countries. And that's partly linked to the effect of the pandemic, but it already started before. And it's partly the crisis of multilateralism and the trust in international organizations. But it also, we have to admit, the lack of prioritization of funding for these areas by countries. So I think that's really an important point. And the second one on accountability is really, again, this multisectoral dialogue and the involvement of citizens in the monitoring of food systems. I mean, that's really where there is very little that is done. The level of misinformation countries and people have on the risks linked to obesity and metabolic disease is incredible. There's been so much misinformation. Sometimes from the government, right? And particularly on the consumption of sugar, but it's changing. And when it comes to accountability, we really need to make all the stakeholders accountable for making sure people are much better informed about nutrition.
Mm-hmm. Thank you. Thank you very much, Agnes. And indeed, and I think the big challenge that we have is also how do we continue to make sure that this is seen as a priority and continues to deliver for the people most vulnerable. Thank you all so much for those first round of reflections and your thoughts, which help us very nicely move into the next segment, in which we will be looking at policy and financing levers for change. And if I could start with you, Aminata, and as somebody who brings in deep country experience, which all the three previous speakers spoke the centrality of, and a country also which has achieved a lot, with a lot of challenges and limited resources. So from your national perspective, what do you see often as a policymaker, as a government official, that are the bottlenecks that you face, whether these are governance or financing related? Over to you, Aminata, and thanks again for joining us from Sierra Leone.
Thank you very much, and thank you for having me in this meeting. Sierra Leone is a small country of less than 9 million people, and over the years, data indicators have not been looking good. But the good thing for us, we've realized our problems, we realize our bottlenecks, and as a country, we're working very hard to unbottle those issues. When we talk about maternal mortality, in 2017, we were one of the highest in the world, 1,165 maternal mortality ratio per 100,000. And then in 2017, it went down to 717. And recently, 2023, we are 354. So we are really working hard to make sure these problems that we have, we don't continue with them. Under 5 mortalities, 94 per 1,000, neonatal mortality. So these are the reasons why as a country, we have that motivation to reduce, to make sure we improve the health of the people. Yes, policy development. In the past, the policies were not that integrated. Nutrition was not integrated in most of these policies. So we did not have a cohesive, integrated policies to make sure we manage issues of nutrition, maternal and young child nutrition problems in the country. And that is one thing. Now we know we have most of the policies, multi-sectorial policies, nutrition is well integrated in the policies. Of course, you cannot talk about the funding. Yes, insufficient funding at country level, and that is something we're working on to have the coordination at the highest level in the Vice President office. We now see domestic resources be channeled into nutrition in the country, and also working hard to have partners to make sure the partners work integratedly. Coordination is very important, because that was also one thing that was affecting implementation at country level. Partners were not always aligned with country's priorities. But now that we have a coordination at the highest level, it's not just scaling up nutrition, it's also the food system hub. And it's going on with a whole new implementation program. And it is very strong. And now the partners knows that we all have to come together. We all have to align to the country priorities. I think that's why we're seeing these changes. Even for stunting, we know that it was high. In 2013, we were like 37%. In 2021, we're 26%, even though it's still high, but we see that it is reducing. The trend is reducing. Of course, data being mentioned, that is something we're working with, because when you're collecting data manually, it is not always the best approach. And then everybody was collecting their own data. But now we have information system at the scaling up nutrition office in the office of the Vice President. So when you come to Sierra Leone now, before when you come, you have to go to the different sectors. You have to come to health, go to agriculture, go to education to get your data. But now when you come, you just go to the SUN office. So we all know that the data should go to that office. So it's a one-shop place where you can get all the information regarding nutrition in the country. And that integration collaboration is very, very important. We're talking about social protection. We're working with NACSA, which is the body for social protection. So whatever policies in there should make sure nutrition is in. If we're giving cash transfer to vulnerable people, we need to make sure we align. If it's pregnant and lactating mothers, we need to make sure it's aligned. Ministry of Health is involved so that we know that exclusive breastfeeding is going on, proper and timely and proper complementary feeding too is going on, and all of that. And then we know that we're talking about nutritious food, nutritious crops in the country. We have Feed Salon. We have initiative. Yes, it's a major problem before. Right now, we have a long way to go to make sure we get the information out there, what people should eat, how they should cook to retain the nutrients in the food, because this has also been a problem with us. People overcook. So we know the problem. So we're finding ways and means, implementable initiatives that will work at country level. We talk about anemia. It's been high. We are one of the first countries to implement MAS at a national level. We know the problems. Once we know, we don't delay in the implementation, because for us, we're playing catch up. We've been very slow. So now we have to accelerate implementation to get to where we want to get. Before we were working in silos. EPI data will be very good, but malnutrition, vitamin A and Albion will not be so good. So now we're using the life cycle approach from pregnancy to the aged. That child is the center. So all the programs that this child is associated with should reach that child. So it's not just in silos now. All the programs should work together, and we are working together. With EPI, we've seen our vitamin A and our Albion coverage going up because of that well integration. So for us, yes, we know the problems have been many: human resource capacity, community engagement, to make sure the community realize to own the initiatives at community level. When we say engagement, we mean proper engagement in every step of the way, from the lowest entity, the smallest village, have a say in what's going on in the health facilities. Infrastructure, sometimes our roads are very bad. Right now it's in the rainy season, and there's some areas that are cut off, especially the riverine areas. We're looking at water ambulances to reach those areas. So when you are down, you have to really think and come up with innovative ideas to improve the health and nutrition problems of the country. And that is what we're doing. Nobody talks about anything without talking about the life stages, because pregnancy, we need to take care of the pregnant woman, make sure they get services, and then the aged. NCD is very high in the country. So we need to make sure we let people know what to eat and how they should eat, reduce salt reduction. And we're going next to sugar and sugary products. So we know we had a lot of, but the good thing about us, we now have a plan to implement so that we can target these many problems that we have in the country and improve our indicators.
Thank you. Thank you so much for that, Aminata, and very clear messages about integration, alignment. But one thing which I have to say, and I particularly appreciate about the Sierra Leonean experience, is how a sense of urgency was brought into the system. I remember Minister Dembe often citing this as how it had to be declared as a national emergency for you to be able to bend the curve and achieve the success that we needed to. And it's a perfect segue also to coming to you, Flavia, next. And, we talk about multi-sectorality, we talk about integration, we talk about alignment, but it is silos. Silos in funding, silos in policies, and those silos often, and you have written, advocated, championed these issues for the longest, and demonstrated how those silos impact women and children's life in most vulnerable situations. Coming from your perspective, Flavia, what are some of the key learnings and how do we move forward in this regard? Over to you.
Thank you so much, Rajat, and dear colleagues, such a pleasure to be with this distinguished group of champions that have advocated for nutrition, for health for a long time. I think we need to do a little bit of mea culpa, and I will explain why, because I think the siloed nature of financing that the global community has imposed on countries for way too long, whether we look at the siloed financing for health through Gavi, through GFF, through the Global Fund, or the siloed financing through project and programs, for example, that the World Bank has initiated. I've been part, for example, of developing community nutrition program that the bank finance in different countries in sub-Saharan Africa. This stream of funding, they come with individuals within the funding agency that are separated and not necessarily connected. And also within the countries, the people that are managing those funds, often the incentives are not to coordinate and integrate, but are actually to maintain the control of that funding streams. So I think, and this, we live, other speakers have alluded, we live now in a moment that is very opportune, because some of these financing streams, for example, through USAID, are really almost halting or coming much, much less into the fore. So how do we change this? I think the previous speaker from Sierra Leone definitely has highlighted the necessity for working across the priorities that the governments have. But also, this includes also the domestic financing, because as long as you have separate siloed funding streams that come, that will not happen. So we need to include and increase the domestic financing. Within the domestic financing also, one aspect that came very, very clear, Rajat, at the Summit for Growth, at the day before, there was a so-called Science Day that AFT organized and asked me to chair and facilitate a discussion around. It's really loud and clear that we need to have sustainable domestic financing that is also integrative in nature. And here, the instrument of social protections are the instruments that are most suited. For example, we looked and we have the evidence that social protection safety net programs in Pakistan, in the Philippines, even examples from Latin America, they work both because they improve food security and prevent shock, and also the food subsidies, we know they work on reducing poverty. And social protection also is important because they are programs that have shown effectiveness in reducing stunting, wasting, and micronutrient deficiency, and therefore breaking the cycle of malnutrition. One thing to note, so far the experience does not show effectiveness on obesity. On the other side, on the side of the other burden of malnutrition that we currently have. So these instruments are, in my mind, also very important, Rajat, because they are particularly useful as they protect family from shock that can also come from climate change. Because let's not forget that now, for example, climate change can provoke flooding, can provoke drought, can have adverse nature events and heat. All of these change the food production system and change the vulnerability of family. But these instruments we have available, they are able to really address the vulnerability within multiple shocks. In one final point I like to make is especially when we discuss about what are our instruments for combating obesity, we as community have worked a little bit stronger, and yes, and you, David, have alluded to, we have had success in working with women, especially pregnant women and children. But the group that is now at stake is adolescents. As adolescents, one lesson I've learned working with adolescents and working with our great chair of PMNCH, that you will remember, Rajat, Madam Gracia Machel, when the adolescents were brought into the constituency of PMNCH, they told us loud and clear, nothing about us without us. And I'm not sure we have developed yet the mechanism for really the full engagement of adolescents in understanding and creating the nutritional value that is important for them. And when working with adolescents, one of the biggest lessons also learned is that we have the real world and we have the virtual world. And we are not really looking at what are our adolescents bombarding by food messages, by promotion of good food, as the other speakers have mentioned. So in my view, also this has to come into the picture, because adolescents can be driver of their own change, but they have to be having the information, the knowledge, and the space for exercising the agency that is so important. In conclusion, I say that I am really heartened by the collaboration that I see in this discussion today, to hope that this collaboration between different partners that have been working for long for women, children, and adolescents, nutrition and health, that we can really together shift towards a more integrated domestic model of financing that will help us achieve those impacts that so far we have had some success, but as David rightly mentioned, they have eluded us, but we are not deterred. We will continue. Thank you. Over.
Thank you. Thank you. Thank you. Here, Flavia. Thank you for that rallying call, and also for spotlighting issues related to domestic resource mobilization and importance of putting adolescents at the heart of it, and much to digest as we go through the next segment of a conversation. But before that, Sean, I want to come to you. And as somebody who's been leading this work at the Helen Keller International, what are some of the evidence-based interventions and tactics that can help us get to scaling up these issues? Because, you know, in spite of all the what we have heard, we do have a significant challenge because these issues remain underfunded and often neglected. Over to you, Sean, and thanks again for joining us.
Yeah, thanks so much, Rajat, for having me. And as others have said, you know, different sectors need to come together on nutrition, but part of that is to make excruciatingly clear what each sector needs to deliver on. And so my comments are going to hone in on the health sector and go back to some of the basics, which others have laid out, that 45% of child deaths are driven by malnutrition. And a lot of that malnutrition is occurring in utero, fetal malnutrition, and it's having devastating effects on mothers also, when you think that 20% of maternal mortality is linked to anemia, because mothers are too anemic. If they have a hemorrhage, they just can't survive it. Does the health sector behave as if 45% of deaths are driven by malnutrition? Absolutely not.
Yeah.
And that's one of the signature messages that came out of the 2021 Lancet Nutrition Series, is there are all these opportunity gaps in the health sector, because unfortunately, the health sector either doesn't have the competencies, nor the funding, nor, in fact, I would say, the accountability to deliver on these life-saving nutrition interventions. So what does that look like? Moms come into prenatal clinics, some now times 8 during times during a pregnancy, and that mom often will not get any counseling on nutrition, will not get even the basic nutrient supplements, will not get dewormed when needed, and will not get preventive treatment for malaria. So we're just wasting her time, and we're wasting the frontline workers' time. So we are really honed in on at Helen Keller International on the health system side of really supporting the health systems to scale up 5 life-saving nutrition actions, from prenatal supplementation through screening and treatment of acute malnutrition. And what are the 3 key levers that need to make that happen? And I will really boil it down to 3 key levers. There needs to be the capacity. So health workforce needs to be trained both in the pre-service curriculum. I think others have mentioned to what extent, in fact, pre-service curriculum is not taking nutrition seriously. David, you mentioned that. And the in-service training. Often there needs to be supplies. I've been in several countries where you talk about it's like, oh, well, we're out of ready-to-use therapeutic food. You're out of iron, folic acid, and there's no cry of outrage. The system is not being held accountable for making those supplies are there. And then there needs to be the accountability that it's not so much focusing on the nutrition outcomes, but are these services being delivered at the scale and quality that will have an impact? Are they integrated into the health information system? When health workers are being supported, are we talking about what these services being delivered. Just to give you one sense of an extreme outlier, we did a population-based survey to look at what mothers' experience had been just in ANC in a number of countries. And I'll cite one country, which is very large, but I won't name it. And it's shocking that 86% of mothers had attended at least one ANC visit. 75% had been counseled on iron folic acid. 2% had received and consumed a minimum of 90 iron folic acid tablets. That's total systems failure. On the other hand, and Aminata, sorry I didn't see you 2 weeks ago when I visited Sierra Leone, but I could see firsthand the total opposite, where every health worker and every mom I talked to knew all about exclusive breastfeeding. Mothers receiving prenatal vitamins, the first country in Africa to go to scale with multiple micronutrient supplements. I got a master's course on how you screen and treat children with severe wasting with or without complications. I attended rehabilitation centers. There were supplies of vitamin A, there were supplies of deworming, there were supplies of prenatal vitamins, there were supplies of ready-to-use therapeutic foods. So it absolutely can be done. And on top of it, we're dealing with interventions that moms and kids love. In so much of public health, we're having to promote some interventions that are just not very pleasant. I mean, who wants to get injected or get an IV? But these nutrition interventions also have a tremendously good uptake. So I think our challenge here is not to say, okay, well, nutrition is this icing or the sprinkles on the cake of the health system. Nutrition should be the very basic cake of the health system. And we need to reposition good nutrition as a marker and maker of quality primary health care.
Excellent. Thank you so much, Sean. And really like the phrase you used, and how do we address the accountability deficit in health system to address and reach those. We are short on time, but there are over 200 people on online, and they have been sending their comments and questions, and I don't want to do injustice to all their engagement. So if I could have a quick 1 minute or less reaction from Flavia, you, Sean, or Aminata, on the question that has been asked in terms of how do we reach those that are actually hardest to reach, for instance, living in rural settings and do not have access to infrastructure, or within conflict disaster settings where we know the needs are compounding and often very hard to navigate. Maybe, Sean, we can start with you, go to Flavia, and then end with Aminata. Sean, any quick reaction?
Community health workers, or I think they should be renamed community health heroes. To give a case in point, in Burkina Faso, where a large chunk of the territory is being invaded by jihadists who target schools, who target official health facilities, working hand in hand with the government, we're able to maintain very high coverage of vitamin A supplementation because they're absolutely the most resilient part of the health system who are there. That goes, I think, across any setting, and all these nutrition interventions, except treatment of severe wasting with complications, in fact, are better delivered by community health workers than anybody else. So to me, the magical sauce for many reasons are the community health workforce.
Absolutely. Thanks for that, Sean. Flavia?
Well, I concur with Sean, number one, completely. And secondly, I would say also, in terms of the reaching the most peripheric parts, I think also work with digital system. We have seen that the opportunity to pass messages on nutrition, information on good nutrition practices through digital apps can also be a modality. I don't think there is yet that wide use, but especially, as I said, for adolescent mothers, that's another vehicle that can help us reach the periphery. Over.
Thank you. Thank you, Flavia. Aminata?
Oh, thank you very much, Sean. Sorry I missed your visit. I want to also concur, community health workers. And for us, below that, we have what we call the mother support groups. They work hand in hand with the community health workers, because we also have young mothers that's within these experienced mothers in the communities can reach easily and all help with the exclusive breastfeeding and information sharing. Sean, that's why when you came, these mothers know about exclusive breastfeeding, how to feed their kids. We know the mother support group, the lead mothers and the community health workers are working very hard at community and hard to reach areas. That's what we need to invest in. And as time goes, the digital app, they all have smartphones. We can be sending messages to them, and all of these will help at community level.
Super. Thank you so much, Aminata, Sean, and Flavia. That was extremely rich and very helpful. Thank you for your time. And also a perfect segue into the last segment of our conversation today with Jane, Dan, and Caitlin, looking at community-led interventions to drive change and impact. Jane, if I could come to you first, and we have heard a lot in terms of importance of community-led interventions, and if we could hear from your lived experience and technical expertise, what interventions have you seen work, and especially in terms of mobilizing young women and communities towards action? Request to all my last speakers, if they could do, please keep their comments brief so we can take some more questions as well. Over to you, Jane.
Thank you. Kindly confirm, Rajat, if you can hear me. Okay. Thank you. Thank you so much. It's nice to be here. For me, what I can share about the innovation that I will be able to do in terms of engaging the community, I work closely with the youths as National Youth Coordinator from Scaling Up Nutrition. We've engaged the youths at the grassroots level. And what really works best was doing the community dialogues. Considering the challenges that the community face, I felt community dialogue really brought a very big impact. Maybe I can share just one of the stories that we're able to experience when you're talking about maternal nutrition. In a community where you live, you find that there are high cases of teenage pregnancy. So when we were doing community dialogue, we also had a chance to be able to go at the facility. And during the antenatal care visit, you notice that out of the 10 mothers, we have the youths, and they're facing malnutrition. So you can imagine one of the major issues that were discussed during the dialogue was that there are no specific youth-friendly services for these young mothers. And that's what we were able to see. As much as we hear what the challenges the people face, we ended up going to the facility to see the real picture of what is really going on. And it was true. Out of 10, we find that five of them were the young mothers, and both were malnourished. So you can imagine the workload, considering the facility, which is at the community, at the dispensary. We have one nurse in charge who is trying to do the antenatal care. The same case with doing growth monitoring. So there's no that special care for these young mothers. So as youths, what worked for us is that we were able to form a youth group where we meet these young mothers at the facility so that you can educate them about good nutrition, considering that the other chances of them, because the issue of child marriage, at the moment they get pregnant, they drop out and they get married. So we ended up forming the youth groups at the grassroots, where we educate them on the importance of good nutrition, and there's still a chance for them to go to school. So their life cannot end there. So for me, that one I felt really worked well, doing the community dialogue. Secondly, when it comes to doing the engagement, identifying the specific stakeholders when it comes to decision making, I identified that men play a key role during these dialogues. One of the major issues you find that we are telling, the mothers are saying, you find a mother is suffering from anemia. You're telling a mother that you need to eat the green leafy vegetables, but you find the mother doesn't have that money to be able to buy those vegetables. So we trying to match to ensure that we have male involvement. And one of the engagement that we did back at the community was to involve the men in these dialogues so that they have the real picture of what is really going on for the mothers, so that they can be able to support them. As much as we tell them that you need to practice good nutrition, you need to eat at least 4 out of 10 food groups, but the mother doesn't have that capacity. So bringing the men during these dialogues, and for us, we tend to look for men where they are best. So there's specific dates for market days. For us, there's Monday and Fridays. So you find men usually go on a market day where they go and sell livestock. So we look for them where they're in large groups so that we can educate them on when you go back home, you need to at least buy this type of food, because you find that most of the men, when they go back, they just go and bring such food like cabbages and potatoes. But the same man who was at the market, he was eating meat. So he just going home with cabbage and potatoes. So it was quite interesting engaging with them. For them, they didn't see it was a big deal. As long as they just take cabbage and potatoes at home, the house will food secure. But the aspect of educating them about the varieties of food, the importance of being able to eat a balanced food, especially for a pregnant mother, was very crucial. And I'm happy that they are the real change makers in the community, because men are well heard. So when you empower the men, they also try to engage other decision makers like the chiefs, so that they ensure that in terms of any engagement, the barazas, they make sure that the men play a crucial role in ensuring that they provide a balanced diet to their wives and also to their children. Yeah, thank you.
Thank you. Thank you for that, Jane. That's remarkable and really great to hear that lived experience and implementation of community dialogues, a series of which that David spoke about at the start of our conversation. And also, how do you engage better the likes of my species so that they are able to provide the much needed support that women require for maternal child health program? Dan, I would like to come to you next, particularly in terms of your experience working in fragile contexts and much of the work that has been done by the World Vision International delivering for these interventions in very complex settings. And what does it look like, and what are some of the lessons learned that we can replicate in other such fragile contexts as well? And welcome again, Dan. Over to you.
So much, Rajat. I'm so happy to see PMNCH in particular advocating nutrition this way. And I'm very humbled by following the wisdom of all of the previous speakers. So this integration in these contexts, for me, it looks focused, it looks integrated, and it looks human-centered. Focused because women and children in particular can't afford for the health system to not effectively and comprehensively deliver the essential nutrition actions. We need for the health system to monitor nutrition, diagnose and treat malnutrition, address micronutrient needs, as well as lead on nutrition education. This means that healthcare workers and health supply chains must fully assimilate the essential nutrition actions. And yet, as Sean was indicating as well, informative research that we conducted last year on essential nutrition action delivery across 268 frontline health facilities in 9 countries, we found, for example, that 1/3 of essential nutrition commodities were unavailable in stocks, and that 20% of the health workers had received no essential nutrition action related training, and over 50% had received no essential nutrition action related in-service training. So this is a big problem that needs to be addressed within the health system itself. It looks integrated because health system efficiency requires of us to combine the delivery of primary healthcare interventions at opportunistic moments, simultaneously addressing child and caregiver health and nutrition requirements. Many of the speakers today have noted this. And it looks human-centered because families should always be consulted on their behaviors, their challenges, their concerns, and their preferences in healthcare design. David noted our work on nutrition dialogues, and Jane was just referring to it, Afshan had referred to it, and these dialogues forcefully reminded us of the importance of community and families' participation, their equitable inclusion, and the importance of context in influencing our design work. We know that if families are not appropriately consulted, important interventions like IFA consumption that Sean was talking about and immunization fail to achieve coverage. And I think that human-centered approaches are even more important where opportunities to develop general health literacy are more marginalized. Ultimately, families need to be empowered to take care of themselves optimally. Now, some examples of what we do. Imagine a frontline health worker who has in his or her hands a job aid that provides an integrated protocol for the diagnosis and treatment of both infectious diseases and acute malnutrition. One healthcare worker, one consultation, one integrated algorithm and protocol for simultaneous diagnosis, referral, or treatment. World Vision, working with our friends at Terre des Hommes and Action contre la faim, has developed just such a digital application for frontline healthcare workers currently being piloted with the Ministry of Health in Mali. It's called Alidia. Alidia moves us in the direction of more comprehensive diagnosis and treatment for sick children and reinforces adherence to national treatment protocols. But it also provides an invaluable job aid to the frontline healthcare worker. As Afshan noted, World Vision has long centered and scaled integrated household and community-level behavior change counseling programs through community health heroes, as Sean is saying, such as our timed and targeted counseling platform, which has a fully integrated 1,000-day focused curriculum, and more recently, our Nurturing Care Group platform, which has an integrated curriculum following the Nurturing Care framework. Community-level approaches like these are invaluable in primary healthcare because they are an effective way to address integrated literacy and behavior at population level, ultimately moving the needles on disease prevention as well as service demand and uptake. While remaining conscientious about workload and complexity, community health heroes remain one of our best opportunities to expand integrated maternal child health and nutrition interventions. And finally, Aminata spoke about the importance of life cycle approaches. My final example would be around growth monitoring and promotion support, which we're scaling both at facility levels as well as decentralized within communities. Iterative or scheduled GMP sessions are those magical moments of family engagement within which we can integrate interventions like immunization, early child development, and even caregiver mental health. That's what pediatric consultations look like for my child and what they should look like for every child everywhere. These examples illustrate integration in tools, in health worker capacity, and in the precious consultation moments health workers have with families. Put them all together, they indicate that integration needs to happen across the continuum of care. Raja, thank you.
Thank you. Thank you. Thank you so much for that, Dan. And really powerful words and concretely showing this can be done. This is being done. I think the challenge for us is how do we sustain the momentum? And as you very poetically said, what's available for our children is available for everyone, everywhere. Thank you so much for sharing those reflections. And coming to you, Caitlin, last speaker for this panel, in terms of co-designing community-led interventions and the experience you have had in terms of what works and what really works. And this is really fascinating because we end up having this conversation at the sidelines of the World Health Summit, and we thought we really needed to share this experience of your work with a wider audience. So over to you, Caitlin, for brief reflections, please.
Yeah, thank you so much for having me. My apologies, I'm a little bit sick, so my voice is not as strong as it usually is. But thanks for all the comments from all of the speakers, really appreciate it. And thanks so much for having us here. I think there's always a lot of lessons that can be learned whenever you're reflecting on an intervention, but there are two key ones for us that we've really honed in on. So the first one is prevention. And our Lucky Iron Life really works in iron deficiency and addressing iron deficiency. And it is far more effective to prevent iron deficiency than to try and bring her iron stores up to a healthy place when she falls pregnant. And so when you also focus on preventing iron deficiency, you have the added benefit of also tackling the root causes and really centralizing your design of your project on the root cause. So for example, iron deficiency is both a cause and a consequence of gender inequality. So if you're going to tackle her iron deficiency and prevent it from happening in the first place, you therefore need to tackle the gendered reasons why she would be iron deficient. So that's lesson number one. And then I think also lesson number two for us has been social behavior change and effective social behavior change. Who the message is, what the message is, and how it is communicated is very important. If the message, do this because it's good for your health, was a message that really resonated, then everybody would have a gym membership. So for example, we were working with an NGO in India, and they started out with this, okay, iron is really important for your body. These are locally available ingredients that are really important to add to your cooking. They were using our intervention, the Lucky Shakti leaf. If you use this, it'll fortify your whole meal with iron. That message really was not getting across. The compliance rates were really low. When they pivoted and made it more of a fun community engagement piece, bring your friends, we would do cooking demonstrations, and this woman would come and she would learn, she would do this cooking demonstration. Here's a locally available ingredient, and please use the Lucky Shakti leaf. And then she'd bring her friend, and her friend was like, what are you doing? That's so fun. This is interesting, made it more of a social experience. Then all of a sudden we saw really higher rates of compliance because the message changed. And I think it's really important to realize that nutrition and health happens in the existence of people's lives. And it's not just sort of a siloed intervention. People have lives and the realities of their lives. And then in terms of innovations, we find, I think it's really important to think about that innovations happen, but we need to think of if it's an adaptable innovation. Because if you've innovated and you've created something that's responsive to your existing needs, then that doesn't necessarily mean it's always going to work in a different community. So using us as an example, our work began in addressing iron deficiency in Cambodia, and it started out as an iron block. Put this iron block in your food and it'll fortify your meal. And that really wasn't resonating with the women because it felt like putting garbage in your food. And so we then adapted our model and worked very closely with the women to adjust. So in Cambodian folklore, the symbol of a fish is the symbol of luck. So when we changed it from a block to a compressed electrolytic iron into a fish, and they put the fish in their pot and that fortified their meal, they started to feel better, which then they attributed to the luck of the fish, hence lucky iron fish. When we expanded into India, no amount of communication around, because of the high rates of vegetarian, no amount of communication around put this fish in your pot was resonating. It just was not going to work. So we needed to adapt again. So that's when we came up with the Lucky Shakti leaf, because that's more appropriate for vegetarians. So it's an example of an innovation, and the core of the idea is there, but it needs to also be adaptable to a local context, because otherwise it's just not going to work. And then I think also when you're thinking about a macro level scale of incorporating interventions into your public health, the more tools that are available in your toolbox, the better, particularly around iron deficiency. It has been resistant to public health interventions. And I think the more tools that are available, the more likely you are to meet the realities of people's lives. So for example, we work really closely with Care Guatemala, and in one rural and remote community that Care Guatemala works in, the women can't have access to iron pills because it's a 2-hour walk to the health center. So they need a different intervention because the iron pills it's not a realistic or feasible for them to walk 2 hours to get an iron pill. So that's where our intervention felt more, resonated a bit more for the realities of their lives. So I think when you're looking at your designing your public health interventions, what existing interventions are you already doing? What are the pros and cons? And are there innovations out there that can fill in the gaps? Understanding that the more tools that you have in your toolbox, the more likely you are to meet the realities of those people's lives.
Thank you, Caitlin. Amazing stuff, and actually, thank you for emphasizing root causes. There is a follow-up question, and we do have a couple of minutes to come back to the panel on that. One is, we often find community behavior hardest to change, and around food and diet issues, it is very hard to navigate at times. So do you have any quick 1 minute or less reflections on that? And then the second thing that came out in chat and Q&A is, we all have lamented the role of community health workers, health workforce, and how important it is going to be. But we are also in the state of massive cuts to budgets. And so how do you think, we would be able to resource this, recognizing the role of health workforce, but also the constraints that they are likely to be working in? Caitlin, quick reflections, and then we go to Dan.
Yeah, I mean, I think the first part of your question in terms of changes in nutrition, I think that goes back to social behavior change and figuring out the message that will resonate. In this particular example that I used in India, what really worked was working with women and getting one woman to influence her friends, who would then influence other people, and kind of realizing that people exist within a social network. And so if their friend starts talking about something that makes them intrigued by something, so if you're doing it, then I'm going to be doing it. So we have found that has been somewhat effective. That being said, I think that is where your social behavior change is really important. And then I think with the community health workers, it's, they're always the champions, but I think just gaining more support for them is always going to be the most important. We saw this at the World Health Summit. They were top of mind on most of the panel discussions. And ultimately, that's the more people that you have, if you need to recruit more community health workers or pay them more money to give them more support, whatever support is needed for them, then that's a better investment than putting more work on them and then not actually investing in their capacity.
Wonderful. Thanks for that, Caitlin. Dan?
Thank you, Rajat. They're great questions. On the behavioral side, first of all, what immediately comes to mind for me in following on the nutrition dialogues exercise that many people have been speaking about is that community members, families, are not beneficiaries. They are agents.
Yeah.
They have agency.
Yeah.
We need to look at them and we need to respect and honor them as the agents, the principal agents for their own health outcomes. And we've said for a long time that if they have agency and they practice positive behavior, they can prevent up to 80% of the disease burden that they incur. That segues into the second question that you raised. If you prevent 80% of that disease burden, how much money do you save on the healthcare delivery side? And how much easier can you make disease work for frontline healthcare workers? But the major message on the aid situation is that all of us working together need to coordinate better. We all need to work together better. We need to coordinate. Many people have been speaking about it. We need to integrate our services. We need to layer them. We are World Vision, for example, we work with many donors, and in Central African Republic, for example, we're delivering immunizations funded by Gavi through Global Fund funded insecticide-treated bed net distribution. We're layering these programs, integrating them, and we have many, many examples of integration like that. We need to do much more of it. That needs to be documented. It needs to become common practice.
Brilliant. Thank you. Thank you for that. And Jane, any final reflections to either of the questions from you? I see Jane's camera is frozen. We'll try and come to Jane later if the technology works. Well, colleagues, with that, we are coming to the final segment of our conversation. And as the time is showing, we are close to the end of our 90 minutes together. I have the great pleasure of having with us Luz Maria, Director, Health and Nutrition from WHO. Luz, I would like to come to you first for your reflections, having heard all you did, and with WHA 78 memories still afresh with the resolution. How do you see the World Health Organization assisting countries deliver on these commitments? And then I would really like to come back to David and Afsan for their final reflections, having heard all this from their perspectives as well. But first to you, Luz, and thank you so much again for joining us today. Over.
Thank you so much. I'm just checking that you can hear me. Perfect. So, first of all, thank you for organizing this webinar and for the invitation to contribute. It has truly been a delight to listen to so many smart speakers talking about the profound impact that nutrition has on people and communities. As I was listening to the speakers, my mind went back to when I was starting as a researcher, my journey in public health at the National Institute of Perinatology in Mexico. And there I witnessed firsthand the transformative power of nutrition in women, particularly adolescent girls who were just about to become mothers. These young women often faced numerous challenges, and they found hope and strength as they received quality of care. It was really inspired to see how something as fundamental as iron and folic acid supplementation, weight gain counseling, diabetes screening could change the trajectory of their lives and the lives of their children. And we saw the same with adult women. So quality of care in this particular group matters a lot. But we know that, and as we have discussed, that many are not reached, many women are not reached with essential nutrition actions, and that inequities persist in access to these interventions. Today, it was very interesting to hear that so many references to overweight and obesity. Indeed, they are a growing pandemic that is affecting pregnancy outcomes and testing the ability of the healthcare to respond to these particular groups. Likewise, the health of migrant women is a high priority. So combining all these pieces to target the most vulnerable is really, really urgent. As it was mentioned earlier, WHO member states extended their global targets to 2030 to give us an opportunity to do more where we have made progress, such as in breastfeeding or stunting, and to really accelerate action where we have been very slow, like an anemia or even lower weight prevention. But I want to highlight that in addition to the outcome targets, WHO approved 6 additional targets to improve process indicators, and they are key to align action and investment in health systems. And to push food systems to deliver healthier diets to the most vulnerable and to direct social protection towards key priorities. So they bring together health, food, and social protection. And those targets are related to iron-containing supplements, minimum dietary diversity in women, minimum dietary diversity in children, counseling of infant for young child feeding, early initiation of breastfeeding, and taxes for sweetened beverages. These actions are critical process indicators to achieve global targets, but they are key to align commitment and investment. And in this area, WHO, as you know, is very committed to continue working to first develop and simplify policy guidance through evidence-based recommendations. We have many interventions that can work, but somehow the essential nutrition actions have grown and grown, and we have lost perspective of what works and what needs to be prioritized as part of a health systems. We have included those in a series of briefs that we are just about to publish to explain the extension of the targets and of course, the inclusion of the process indicators and how to drive progress towards 2030. The second area where WHO will continue working, of course, is providing technical supports and collaborating with partners, as many as some of them are here in the call, but also through other partnerships like the Global Breastfeeding Collective or the Anemia Action Alliance. They need to own these outcomes because they are drivers of change as well. And unless we align the priorities of everyone, it's going to be very difficult to make the progress. Likewise, it was mentioned today, it's very important that we modernize the information systems. And we are working towards that direction because the way of using data has changed in the recent years, and the systems need to be modernized. And importantly, in one of these areas is we are supporting countries in their efforts to update their fiscal policies to deliver healthier foods, but also to tax unhealthy products, not only sugar sweetened beverages, but also foods that are high in fats, sugar, and salt, and unhealthy fats that can be taxed, and through that, improve the domestic resource mobilization. Very few funds, and this is a tricky topic, very few of the taxes, the health taxes, are earmarked for the health system or for nutrition actions. We need to ensure that the right conversation happens. At least it's not only to increase the resource mobilization, it's to increase the resource mobilization to ensure that it's allocated to the right outcomes. And we are working with countries in that direction. And of course, as Sean mentioned, we are deeply committed to ensure that nutrition is the basis of the healthcare, not an add-on. Is the basis of the healthcare, very closely linked to maternal nutrition to non-communicable diseases and to infectious diseases, because it's a cornerstone of health. And with that, I just want to say one additional piece, which is we only have 5 years to achieve these targets, and we will hear this all the time. And I was in a meeting recently with Dr. Tedros, and he said something that really stuck with me. He said 5 years is very little time, or is a lot of time, depending if we are able to really feel the sense of urgency and to convey the sense of urgency. I hope that we can really convey the sense of urgency to everyone.
Thank you. Thank you so much for that, Luz. Really, really appreciate all the reflections that you shared with us, and also ending with that sense of urgency. And to come bring us to a conclusion, I would really like to invite our two opening speakers for their final reflections and any suggestions for next steps. David, if I could come to you first, and then we end with Afshan. David, over to you.
Thank you. What a wonderful seminar, well organized. Look, nutrition is coming up. It's rising up the political agenda. Not fast enough, but it's coming up, and we've all got to do more. And here are 4 things. 1, it's everybody's business, not just the health sector, not just the agriculture sector, not just social protection, not just women's organizations. It's the business of the whole of society. Second, we have to widen engagement and engage everybody. I know there are some that we're nervous about involving because we think they're part of the problem, but we've got to engage them all and have everybody focused on it, because the epidemic, particularly of obesity and non-communicable diseases, is just growing. Thirdly, we've got to integrate nutrition into every single activity. And number 4, we must do it transparently, telling everybody what we're doing and being ready to be called to account. We've not done well enough, got to do better. I want to be part of it. Thank you.
Thank you, David. We have to do better. Afshan, for the concluding remark, please.
Thank you very much. I think when I listened today, I've heard some very clear messages. First, that nutrition is foundational, not optional. And when countries localize nutrition interventions through integrated systems, frontline investment, and inclusive governance, maternal and newborn health outcomes improve cost effectively and sustainably. The second thing, and it's come out loud and clear, with the rising rates of overweight and obesity, a good solid investment in nutrition is part of the prevention that's needed. Most countries, most governments will never have enough resources to tackle overweight and obesity medically, nor should they have to. So we really need to make sure that the prevention agenda is up there front and center, and that'll require working with multiple actors, as David just mentioned. The third thing I want to come back to, and because it is the elephant in the room currently, and it is the financing. And I do think one is keeping, as Agnes and others said, a clear illustration of where are new modalities for financing concrete interventions. Secondly, in the chat, I think innovations around health insurance systems that can, and incentives using fiscal policies to get populations to also contribute in some instances where feasible. Thirdly, I think everyone's focused a lot on the domestic budgets, but we do need to see what's the return on investment on those budgets, and how do we get to better streamlining, bundling services, and efficiency gains. And lastly, I would say when it comes to the development banks, Anna spoke a lot about the social protection angle and the long-term impact that has. I also see the reticence from governments to borrow concessional financing to invest in what's called the soft sector. I clearly think we need better arguments on why investing in human capital, in better health and nutrition, boosts also longer term gains, whether it's workforce productivity or human capital, or the ability for adolescents and young people and women to contribute to the economies. Those arguments are equally important to convince ministers of finance and others to look at alternative ways of financing some of the social sector budgets in a longer term and more deliberate manner. So thank you, Rajat, for bringing us all together. Thank you for the opportunity. And I think in terms of the way forward, we have this year a number of important events. Forthcoming is the Financing for Development piece, and we will need to make sure that investing in nutrition and integrating nutrition into other sectors to deliver more effective outcomes is a key piece of that discussion going forward. Thank you so much again.
Thank you so much for that, Afshan, and to all the partners. It's been such a delight hearing this conversation. And I'm not going to try and summarize and delay our conversation any bit further. But I have to say, one thing which came across from this conversation, from the three panels that we had, is the need and imperative for us to work together, to bring our movements together and truly bring across movement collaboration to deliver on nutrition, not just for women and children, but as a core foundational aspect of global health overall. Thank you, colleagues, for joining us, and I hope you have a lovely rest of the day where you are. Thank you.
Thank you very much, everyone. Thank you.
Bye-bye. Thank you.
Thank
I
you.
loved it. It was a wonderful seminar.
Agreed.
Hope we can stay in touch. Bye-bye.
Agreed.
Thank
Absolutely.
you.
Thank you, Caitlin.
Never sure for it's good.
Very
I'm
nice.
sure when you leave or you're good to go. I think we're good.
Yeah, good. Calling in from Vancouver must be quite early.
It's about 6:30, started at 4:50, so pretty early.